So limitations of multicolor flow, as we've alluded to, not all leukemic cells have an abnormal phenotype. What you're often trying to differentiate is between abnormal and normal. The immunophenotypic antigen shift can occur between diagnosis and relapse, and this leukemic antigen immunophenotype, or LAIP-like phenotype, may represent normal or regenerating marrow. There can be significant numbers, there are significant numbers, and I'll show you the data, in MRD negative patients that still relapse, and contrary. There are significant patients who are MRD positive who are cured. There's lack of standardization, variations in machinery and fluorescent intensities, and clear operator-dependent interpretation. You need to have a good expertise in order to analyze this. Moving on to the next modality, which is RT-PCR, which really is only sufficient in a subset of patients with MRD. And here we look at the publication from last year, Dr. Ivey and colleagues looking at NPM1 positive patients. And you can see about a third of patients who are MRD negative after 2 cycles of chemotherapy still relapsed. And then on the flip coin, about a quarter of patients who are MRD positive after 2 cycles of chemotherapy seem to be cured. So how do we interpret this, and what are we going to do about it? More disturbing is a publication from Willikins in the Hematologica last year again, showing different results depending on whether the MRD was measured from the bone marrow on the left, showing no difference in terms of relapse-free survival, versus if it was done on the peripheral blood. So another issue in terms of validation of this technique. So again, limitations of the RT-PCR approach, applicable only to a limited number of patients or subtypes of AML, specifically NPM, as I've showed you, or maybe core binding factor. Proper intervention is still undefined for this modality, and the sensitivity of the test for predicting outcomes. Again, just to reiterate, non-trivial numbers of MRD negative patients will still relapse, and a significant number of patients who are MRD positive seem to be cured. So again, my colleague has well published, so it's always nice to use his own studies. So from Seattle, a study of 100 patients, and these are pre-transplant MRD analysis, showing that after transplant, the most intensification that we can use for our patients, 65% of patients still relapsed, with the survival rate at 24%. So clearly transplant, based on this study, was not able to salvage MRD. And further analysis shows that, again, with other publications, that the allogeneic stem cell transplant approach does not attenuate the risk of relapse in those patients who are MRD positive. Reiterating this message that I'm trying to send is I don't know what to do with the information. In addition, intensification of the bone marrow transplant conditioning regimen. If you go from a non-myeloablative approach to a myeloablative approach, again, you're not able to salvage those patients who are MRD positive. Again, what do we do with the information at hand? Even in our pediatric colleagues who now have approaches to intensify therapy, to look at that validation in the setting of a clinical trial. But in this analysis, in the pediatric population, MRD by multicolor flow was still, those patients who were MRD negative still had a significant relapse, 40% or so. So what about next generation sequencing? Error rates, intrinsic to most conventional NGS. The depth of sequencing is an issue. Limitations in that argument. The algorithm is important. Persistence of genetic mutations in long-term remission. That is clonal hematopoiesis that we've learned about. Somatic mutations, for example, DNMT3A, can still be found in healthy individuals. CHIP has been notified. This was a survey that Jeff Lancet, and he sent me this slide, sent to 13 major academic centers. And I think that the answer here really answers the question that we've been begged, is that it's all over the field. Nobody really is doing a unified algorithmic approach to MRD and AML, number one. And number two, nobody knows how to interpret the data outside of a clinical trial. I'm all for studying this in the setting of a clinical trial, where there are clinical trial approaches in order to determine whether or not a targeted approach or intensification may augment it. But outside of a trial, I think it's really difficult to present this to our patient. So major question, how to deal with the results. Again, lack of randomized trials to guide appropriate intervention. in the setting of MRD. The presence of MRD usually predicts a worse outcome, no doubt. My colleagues showed that. But more aggressive measures such as bone marrow transplant seem to be ineffective in salvaging patients who are MRD positive. Lack of certainty as to the ultimate prognosis and risk of relapse, despite clear trends being present. Is therapy for MRD always indicated? Remember, a quarter of patients will still be cured. What is the optimal level of sensitivity? I don't think that's been well established. And let's not forget the psychological burden that this places on a patient. You have a higher risk of relapse, but I have no idea what to do with it. And so that individual is going to live the significant amount of their life trying to be worrying whether the shoe is going to fall. And as I'm trying to move to the next slide, there we go. And so my conclusion slide, until standardization of techniques and difficult to interpret results outside of a clinical trial, the exception is APL is noted. However, it may be in the arsenic era, this may be moot. I think we need further trials. I'm all for clinical trials to determine the role of MRD in clinical practice. That is, what do we do with the results? But until then, my argument, Dr. Walter, would be that the use of MRD should not be part of routine clinical practice. And with that, I'll end. Thank you.